Good afternoon, everyone. Just want to call this meeting of HHS Health and Human Services Subcommittee to order. Today we'll have one agency briefing, which will be MDH Medical Care Programs, and it will be read by the phenomenal budget analyst Ann P. Wagner. Ms. Wagner.
Thank you very much, Mr. Chairman, members of the committee. As you said, I'm presenting the budget analysis for the Medical Care Programs Administration. This is the administration within MDH that manages the Medicaid program and the Maryland Children's Health Program. The fiscal 24 allowance provides $12.5 billion for this program, which is a $447 million decrease from fiscal 23. Medicaid and MCHIP are joint state and federal programs, and Maryland receives at least a 50% federal match for qualifying Medicaid spending, with certain populations receiving enhanced matches, like children under MCHIP receiving 65% federal matching funds, and childless adults under the Affordable Care Act or ACA expansion receiving a 90% federal fund match. And so this leads to the Medicaid budget being predominantly supported with federal funds each year. That fund split does fluctuate slightly from year to year. And I'll point out that Maryland also received an enhanced federal match during the COVID-19 public health emergency. And so that's contributing to the shift in the fiscal 24 fund split so that more general funds will be needed compared to the prior years. I'm going to discuss the program description very briefly. Medicaid provides comprehensive health benefits to eligible individuals who meet certain income thresholds or are considered medically needy. And then MCHIP extends eligibility for healthcare coverage to children with higher family incomes than the cutoff for Medicaid. And so Exhibit 1 shows broad categories of Medicaid enrollees, and it compares each group's share of enrollment to the share of spending in fiscal 22 as an example year. This exhibit shows that some smaller eligibility groups drive program costs as they make up a much larger share of spending compared to their share of total enrollment. And so this is true for disabled adults and children, as you're seeing this group accounted for just under 8% of total enrollment, but 22% of costs. And so these populations require higher cost services and higher healthcare utilization overall, leading to this trend. But on the opposite side, other children enrolled in Medicaid and MCHIP make up 41% of enrollment, but then only 18% of total program costs. Exhibit 2 on the next page shows that the vast majority of enrollees in Medicaid, at 87% as of November, were served in the managed care program, referred to as Health Choice. Under this program, each individual is enrolled in one of 9 managed care organizations or MCOs. MCOs are paid a capitated rate to provide Medicaid covered health benefits to their members. Other individuals not in the managed care program are mostly Medicaid enrollees in long-term care facilities and individuals dually eligible for Medicaid and Medicare, and this group receives coverage on a fee-for-service basis. I'll now turn to the performance analysis section, and that starts off with MDH's monitoring of MCO performance. That page lists a few different ways that the department tracks MCO quality. This analysis will focus on HEDIS measures and the value-based purchasing program. First, HEDIS measures are a performance monitoring tool used by health plans nationally. They look at a wide variety of quality domains and components. And so looking at Exhibit 3, I'll zoom out a little bit. This exhibit shows how Maryland MCOs performed in the past 3 calendar years. This shows the percent of measures that are equal to or above the national mean. In calendar 21, the MCO average was just over 50% of HEDIS measures being equal to or slightly above above the national mean. And there has been a pretty sharp decline in performance since calendar 2019 across almost all of the MCOs. This timing does overlap with the COVID-19 public health emergency, but we would also expect other health plans nationally to be impacted by the pandemic. And so MDH is asked to explain why Maryland MCOs reported worse HEDIS outcomes in calendar 20 and 21, and if there are any reasons that the MCOs would have been disproportionately impacted by the pandemic compared to other health plans nationally. So I'll skip ahead to the next item that has to do with the value-based purchasing program. Under this program, MCOs receive certain incentives or are charged disincentives or penalties up to 1% of their capitated rate. This depends on their results on certain healthcare quality measures that are chosen by MDH, and the 7 measures used in calendar 21 are listed on page 13. Originally, this program was designed to be budget neutral because the charged penalties would pay for the earned incentives. And so that first round of incentives paid out was the primary distribution. But if there were more penalties collected than what was needed for the incentives, then there would be a secondary distribution of bonuses that were provided to the top 4 performing MCOs. This program could no longer operate exactly that way because of a federal requirement that MCO rates had to be actuarially sound. And so because Maryland's rates were set at the very bottom of the range to be actuarially sound, charging disincentives or penalties would push certain MCOs below that level. And so this led to MDH implementing the program with incentives only in calendar 2018. And then in calendar 2020, MDH only charged penalties to 0.5% of capitated payments to maintain that required level. Exhibit 5 shows the VBP result in calendar 21, with most MCOs falling in the disincentive range. However, the MCO rates were again set at the bottom of the range to be considered actuarially sound. And so MDH is not charging penalties or disincentives and is covering the $2.7 million in earned incentives with funds in the fiscal 23 working appropriation. If the program was operating as it was initially established, there would be about 28 million more in penalties than in incentives, and that would be distributed through a secondary distribution. The BRFA of 2020 changed the way this secondary distribution was to be paid out, beginning with calendar 21, and that new methodology is described on the next page. However, the calendar 21 value-based purchasing report only published the primary incentive payments and did not provide any calculations for a secondary distribution. This is despite the working appropriation, including funds to cover value-based purchasing costs. And based on calendar 21 results, that amount would have been, the amount of funding in the budget would have been at least 4.5 million more than needed if a secondary distribution was paid out. And so the department is asked to clarify whether it is implementing a secondary distribution for calendar 21 and to discuss how it's planning to spend any remaining funds budgeted for this program in fiscal 23 if a secondary distribution is not being administered. And so considering the issues with charging disincentives, MDH has transitioned to a new incentive-only program that's referred to in regulations as the Population Health Incentive Program, and that will be implemented for the calendar 22 MCO results. And so the fiscal 24 allowance includes $36 million to fund the first year of this program. I'll now move over to the fiscal 23 discussion. Page 17 includes a discussion on the 4 proposed deficiencies across Medicaid and MCHIP that would add a net total of $720 million, mainly due to increased enrollment assumptions that I'll discuss later on in this presentation. I did want to highlight one special fund adjustment made in this deficiency related to MCHIP premiums. As part of the Maryland Children's Health Program, children with family incomes above 212% of the federal poverty level normally pay monthly premiums. These payments were suspended during the COVID-19 public health emergency by a state level emergency order. And so the department is asked to comment on when it plans to resume collecting these monthly premiums. 2 proposed deficiencies account for the continued 6.2% enhanced federal match on Medicaid spending and 4.34% enhanced match on MCHIP spending that was initially tied to the national COVID-19 public health emergency. Exhibit 6 shows the federal funds that Maryland received, totaling between $400 and $500 million per year from fiscal 21 through 23. The enhanced match is set to phase out beginning April 1st until the enhanced match fully expires at the end of this calendar year. So that's why you're seeing the decline in federal assistance between fiscal 23 and the allowance in 24. As a result of the enhanced match ending, more general funds will be needed in the allowance to backfill this support. And so while total Medicaid spending is decreasing in the allowance, you are seeing a general fund spending increase of over $500 million. At the top of page 19 of the analysis, there are 2 items discussed that were added by budget amendment in fiscal 23 that were supported with federal funds from the American Rescue Plan. $50 million was provided to help stabilize Medicare Advantage plans operating in Maryland, and $25 million supports skilled nursing facilities, mainly for staffing costs related to the COVID-19 pandemic. So the department is asked to provide an update on how the American Rescue Plan funds were distributed and when they will be spent. The final fiscal 23 item I want to highlight relates to the MCO risk corridor. This is a risk sharing arrangement that the department and MCOs entered into midway through calendar 20 to share in savings or losses while healthcare utilization was very uncertain during the pandemic. MCOs annually spend a percentage of their capitated payments on eligible medical expenses. That's referred to as the medical loss ratio, or MLR. MDH normally requires MCOs to report an MLR of at least 85%, or the department can recover some of the difference. And under the two-sided calendar 20 risk corridor, MDH and the federal government agreed to split losses with the MCOs if they spent above certain MLR thresholds, or would split savings if MCOs spent below certain MLR thresholds. Exhibit 7 shows the MLR ranges that resulted in savings, and that shows that 5 of the 9 MCOs fell in those corridors. This led to $106 million in total recoveries between the federal and state government, with MDH's share being $35 million. And so MDH is asked to provide an update on the timing and method for the $35 million in recoveries to be accounted for in the state budget. Moving to the discussion on the allowance, I'm going to jump ahead. Exhibit 9 on pages 23 through 25 outlined the changes between the fiscal 23 working appropriation and the fiscal 24 allowance. This sums to a net decrease or reduction of $447 million. And then I'm going to actually skip ahead to the budget discussion that begins with Exhibit 10 on page 26. This exhibit shows special funds budgeted under Medicaid and MCHIP in fiscal 23 and 24. It reflects that the allowance decreases by about $77 million in special funds. This is mainly driven by a $50 million reduction in the Medicaid deficit assessment, which is imposed on hospitals in Maryland, and that would be backfilled with $50 million in general funds. Both the special fund reduction and the general fund backfill are contingent on this year's BRFA. And so you'll hear more about this during the budget hearing for the Health Regulatory Commissions next week, but this is one of multiple actions that HSCRC, or Health Services Cost Review Commission, recommended to increase Medicare savings to try to help the state meet targets under the total cost of care model. HSCRC also received federal approval to increase the public payer differential in fiscal 24, and that allows Medicare and Medicaid to pay slightly lower hospital rates. And so this is estimated to provide $26 million in Medicare savings, but would also provide $16 million in Medicaid savings that are not yet shown in the allowance. And so moving on to the next special fund item, the remaining special fund decrease is attributed to the cigarette restitution fund, as support for Medicaid with that fund falls by $29 million. With just $46 million budgeted in the allowance for Medicaid, the cigarette restitution fund is estimated to close fiscal 24 with a balance of about $19 million. Considering this large closing balance compared to prior years, DLS recommends reducing $15 million in general funds from Medicaid and authorizing a budget amendment to replace the funds with an equivalent amount of available cigarette restitution fund special funds. Next, the analysis discusses provider rate increases under Medicaid. Exhibit 11 outlines the funding for rate increases, with nursing homes and MCOs driving the overall $215 million increase. Nursing homes receive the 4% increase as required in chapters 10 and 11 of 2019, or the Fight for 15 legislation. Home and community-based services providers also receive the mandated 4% rate increase in fiscal 24, but this is offset by the end of a one-time additional 4% rate increase that's supported with federal American Rescue Plan funding that was budgeted specifically for, or was provided specifically for home and community-based service expansion. And so that one-time rate increase ends after fiscal 23, offsetting the 4% in fiscal 24. I will note this exhibit excludes funding under the MDH Office of the Secretary that accelerates the mandated provider rate increases contingent on the enactment of legislation accelerating the $15 minimum wage. So that funding was discussed in the MDH administration analysis, but I'll note that the increase for Medicaid providers receiving the mandated rate increase would be accelerated to 12% in fiscal 24 when those funds are included. In fiscal 23 and 24, home and community-based service providers continue to receive additional rate increases that are funded with American Rescue Plan funds. This issue was discussed at length in the health overview presentation, so I won't go too much deeper into this, but I did want to note that Exhibit 12 shows the HCBS provider rate increases specifically for Medicaid, including the 5.2% rate increase that becomes ongoing spending as the allowance backfills the federal support with state funding after the ARPA funds must be fully expended by April 1st, 2024. The analysis then moves on to a discussion of Medicaid and MCHIP enrollment trends, starting out with Exhibit 13. This shows the substantial growth in Medicaid enrollment from fiscal 19 through the current fiscal year due to the requirement that state Medicaid programs freeze disenrollment as a condition of receiving the enhanced federal match during the COVID-19 public health emergency. And so over this time period, there's over 25% growth in the average enrollment per month. And then I'll move on to the next exhibit. I'll focus mainly on the third bar labeled COVID-19 PHE growth. This shows the added enrollees between February 2020 and January 23 by their eligibility categories. And so while the ACA expansion group made up between 20 and around 25% of monthly enrollment, this group made up a larger share at about 40% of the new enrollment added during the pandemic. I want to note here that the Medicaid enrollment mix can have a large impact on general fund need for the program. For example, the ACA expansion group receives a 90% federal fund match. And so increased enrollment for this group would greatly increase total fund cost under Medicaid, but has less of a general fund impact versus groups like parents and caretakers that typically receive a 50% match. And so they received a 56.2% enhanced match during the PHE. And so moving forward, the Consolidated Appropriations Act passed in December decoupled the end of the freeze on disenrollment from the end of the public health emergency. And it instead allows states to begin a 14-month redetermination process on April 1st, 2023. I'll show this on screen, but it's just a lot of text, so I'll just describe the process. And so the planned redetermination process in Maryland is described on page 32. Overall, MDH plans on using the maximum 14 months allowed to work through the first round of redeterminations. MDH has been conducting eligibility renewals throughout the pandemic, but the first renewals that could end in disenrollment will start up again April 1st, with Medicaid coverage being terminated for the first group starting June 1st for people who are found to be ineligible. Most Medicaid enrollees will go through the process in the month that they first enrolled in Medicaid or MCHIP, but there is a group of about 186,000 individuals that MDH has identified as likely ineligible. That could be due to the individual reporting an income that's too high to be Medicaid eligible, or the individual aging out of Medicaid and into Medicare, among other reasons. And so MDH is prioritizing these individuals for the renewal process in the first 6 months. And I'll note that this number at 186,000 individuals is significantly higher than prior estimates when the department reported approximately 55,000 individuals would likely be ineligible. In last year's budget bill, Medicaid funding was restricted pending the submission of quarterly reports on the redetermination process and the status of the public health emergency back when it was still expected to end before fiscal 23. And so the department has submitted one quarterly report on January 9th, and in the analysis, DLS is recommending the release of $250,000 of the restricted funds unless there are any concerns raised by the subcommittee. Considering the freeze on disenrollment ending on April 1st, DLS is again recommending budget language restricting funds pending the receipt of quarterly reports on the redetermination process. Next, moving on to Exhibit 15. The analysis discusses DLS's fiscal 23 and 24 enrollment forecast as it compares to the enrollment assumed in the budget plan. Both forecasts project significantly higher enrollment in fiscal 23 than was originally budgeted in the legislative appropriation. That's due to the COVID-19 PHE being extended multiple times. And so therefore the freeze on disenrollment was pushed further and further back. There is a deficiency that adds about $685 million to Medicaid to cover this increased enrollment and to update the budget for utilization and rate changes. And then with this higher starting point in fiscal 23 enrollment, the fiscal 24 allowance is then based on much lower average monthly enrollment as disenrollments are expected to start back up after April 1st. Due to the decline in enrollment from over 1.7 million in fiscal 23 to 1.56 million in fiscal 24, Medicaid spending in the allowance decreases by more than $900 million compared to fiscal 23. And so that reduced spending also accounts for utilization assumptions, but the largest factor is decreased enrollment. While both the budgeted enrollment and DLS enrollment forecast showed this large decrease from fiscal 23 to 24, the assumptions on enrollment mix by eligibility group between the two models lead to slightly different estimates of total Medicaid spending and general fund need. Exhibit 16 shows recent and actual enrollment trends among children and parents enrolled in Medicaid, showing the gradual increase while disenrollment has been frozen. The dotted lines show that for children, the budget and DLS assume that fiscal 24 enrollment will decrease as those disenrollments start back up. However, looking at the trend for parents and caretakers, the budget assumes that the parents group will remain at the elevated level, while the DLS forecast projects that this group will see a similar trend to children and would decrease once disenrollment begins. Turning to the next exhibit, this takes the per person cost in the allowance and estimates the cost impact of those enrollment differences by category in the two models. The 47,000 person difference in parents and caretakers would lead to about $290 million in reduced total fund cost and has a significant general fund impact of over $100 million in less general fund spending due to the 50% federal fund match that this group receives for the parents and caretakers. So even though DLS ends up slightly higher in enrollment for some groups like children in Medicaid and the ACA expansion group, the large difference in projected parents and caretaker enrollment drives an estimated net cost difference with the DLS forecast projecting about $100 million in less general fund spending than is included in the allowance. And so to sum up this enrollment discussion, DLS found that the fiscal 23 working appropriation as adjusted by deficiencies is adequate to cover projected costs, but the fiscal 24 allowance is overfunded based on the anticipated enrollment mix. I had also mentioned that estimated $16 million in savings that Medicaid would receive from the HSCRC cost saving actions. And so combined with enrollment projections, DLS is recommending a reduction of $115 million in total funds from the Medicaid budget in fiscal 24. I'll now move along to a short discussion on personnel. So I'll jump one more ahead. Medicaid receives 11 contractual conversions in the fiscal 24 allowance, but at the same time, there is a net increase of about 56 contractual full-time equivalents. Many of the new contractual positions have similar roles as those 11 contractual conversions, and these positions are being added as Medicaid reports over 80 vacancies as of December 2022, with almost 25 of those vacant positions being vacant for more than 1 year. And so MDH is asked to explain why the net increase of 56 contractual positions is best served with contractual personnel rather than as new regular positions or being repurposed long-term vacant regular positions for these staffing needs. I'll briefly run through the issue section. The first item relates to an audit that the Office of Legislative Audits, or OLA, annually conducts on closeout transactions. The fiscal 24 closeout audit found that MDH has an automated tracking system for federal fund revenue accruals. And when OLA sampled 16 entries from that tracking system, MDH could not support the propriety of $3.5 billion in federal fund accruals. The audit specified that MDH's automated tracking process did not collect enough information to be certain that the federal fund accruals could be recovered in the next year. And so MDH is asked to discuss how it is resolving this significant audit finding, including how it is changing the internal accrual tracking and when those changes will occur. The second issue has to do with the various changes made to the Medicaid program recently that generally expand healthcare coverage. I'll highlight that legislation from last year required Medicaid to begin covering certain dental services for adults by January 1st of 2023. Previously, only children and certain adults qualified for Medicaid dental coverage. And so the department is asked, sorry for scrolling, the department is asked to provide an update on the implementation of the adult dental coverage. The other item I'll note is the third on this list. It relates to the Community Options Waiver Program. I discussed how these I discussed these changes in the health overview presentation more at length, but I just want to highlight here that DLS is recommending narrative, requesting 2 reports on the community options waiver and community first choice program, specifically on their financial and registry data. Finally, I'll briefly discuss the recommended actions. They're found beginning on page 42. I'll skip recommendations I've already described, but looking at items 2, I won't show them all on screen, but items 2, 7, and 8 are all language or narrative that requests reports that were requested in last year's budget bill or joint chairman's report, and they still haven't been submitted. And then items 3 and 9 are restrictive language recommended annually that prevents funds for Medicaid provider reimbursements and the Maryland Children's Health Program to be transferred out of those respective programs. So with that, I'll conclude the presentation. I'm happy to answer any questions.
Thank you, Ms. Wagner. I did have one question that came more from constituent that brought information to my attention. On page 39, you talked about the OLA audit report, and you talked about the $862.5 million is mentioned in the analysis from that report. And then you also, it looks like it says those funds were subsequently request and recover the federal funds of September 2022. I just wanted to make sure that those funds were claimed.
Yes, I believe after being prompted by OLA, MDH did claim those funds.
Okay, perfect. At this time, I'd like to bring up MDH. You snuck in on me, Dr. Scott. I didn't see you.
Or keep going. Secretary of Health, with me is Trisha Roddy, Acting Medicaid Director, and our Chief Financial Officer, Emily Brandenburg. Also available for questions are Jennifer McElvaney, who's the Finance Director for Medical Care Programs, and Webster Yee, Assistant Secretary of Health Policy. I do want to share that Webster will be leaving the Maryland Department of Health, and he will be going to DHS, working with Secretary Lopez. I want to thank Webster for all his years of service at the department and me personally, not only going through the nomination process, but getting me through the first 6 weeks of Secretary of Health. So thank you, Webster, and we wish him well in his new role as Chief of Staff at DHS. I want to thank Ms. Wagner, as always, for your insightful analysis. Before I turn it over to Trisha Roddy, I just want to highlight 2 items for the committee. Over the next several months, one of our top priorities is successfully unwinding policies related to federal COVID-19 public health emergency. And that includes not only our testing and direct things related to COVID, but certainly the unwinding of a key policy that's coming to an end related to continuous Medicaid eligibility. As a result, enrollment in Medicaid has steadily risen during the public health emergency, consistent with national trends. We will resume Medicaid eligibility as of April, and we expect some individuals may lose Medicaid coverage. Changes in eligibility status may occur due to changes in income or household circumstances. It is imperative that Marylanders who are no longer eligible for Medicaid have the opportunity to access affordable, high-quality healthcare coverage, including through the Health Benefit Exchange. And we are going to be partnering with the managed care organizations, the Health Benefit Exchange, Department of Human Services, CRIS, which is the State Health Information Exchange, and others, using a combination of targeted outreach and paid media campaigns to reach every affected individual. Unlike in other states, Maryland never stopped its eligibility checks during COVID. However, we take seriously our responsibility to make sure that all of our Medicaid beneficiaries have every opportunity to maintain their access to healthcare coverage. The second priority, which Ms. Brandenburg will discuss further in our response, is our recent Office of Legislative Audits FY22 closeout report. The department agrees corrective actions are necessary to strengthen the accounting practices and documentation at MDH, and that while the corrective action will take some time to complete, the current administration, including leadership of both MDH and DBM, are committed to prioritizing this effort. I wanted to extend a special thanks to DBM Secretary Grady and her team, as well as Greg Hook's legislative audit staff, for their help over the past few weeks on this issue. And with that, I will turn it over to Trisha Roddy, who will go through a summary response of our DLS to the DLS analysis.
Thanks, Secretary Herrera Scott. And both Amelie and I will be sharing this portion of the presentation. So first, we were asked to respond to why the Medicaid health choice performance differed from the national scores, HHS scores. And we don't have a concrete response to this. I mean, what we can say is it was a global pandemic. And each state's response to that global pandemic varied. For instance, in Maryland, we closed adult daycare centers. I'm not sure that happened across the country. But what we do know, and it's been well documented, is that healthy individuals just weren't seeking care like they normally did prior to the pandemic. We have heard across the state all the different staffing challenges providers had during the pandemic, and we're still hearing about those staffing challenges. We do know offices were closed and there were service consolidations happening across our provider networks. The other item that I point out is when you collect HEDIS measures in order for them to be reported, not all of them come from claims. Our claim system. Some require you to go into the medical offices and do chart reviews. And of course, obviously during that pandemic, they wanted to limit the number of individuals going into those settings. There was some flexibility given, but that was a significant limitation of different MCOs being able to report on certain measures. And although we allowed and we are continuing to allow providers to provide services via audio only for our telehealth practices, it didn't overcome the underutilization that was being experienced across the state. Next, we were asked to comment on our value-based purchasing payouts for calendar year 2021. As I testified yesterday in the House, it's important for us to go back to calendar year 2020 in order to understand where we ended up in 2021. So when we sign our contracts with the MCOs, we sign them annually, and they usually happen the fall before the calendar year begins. So when the pandemic hit in March of 2020, our contracts with the MCOs were already signed. We weren't able to change those contracts. And so in the contract, we were obligated to follow the value-based purchasing program as written. That meant that we had to collect all the disincentives, regardless of performance or on where the actuaries had certified our capitation rates. In addition, it required us to pay out all of those monies, regardless, again, of performance. The payout in the second round required all of the monies left over to be paid according to the highest performing MCOs. Again, some of those MCOs had net disincentives, but they still received money. Now, of course, we didn't want this to occur in calendar year 2021. So we made sure that the contract stated that if in fact the capitation rates could not be certified by the actuaries and support the collection of disincentives, we would not collect those disincentives. And yes, in fact, our actuary said that our calendar year 2020 rates would not support any collection of disincentives. This was communicated to the MCOs, so they knew we would not be collecting those disincentives. The contract did allow for some payout of incentives if in fact there were money contained within a health choice performance fund. There was some money in that fund that allowed us to pay about 90% of the incentives achieved in round one for the two MCOs that qualified. And those two MCOs were Kaiser and Jai. And as Ann mentioned, in calendar year 2022, we are moving to a new program called the Population Health Improvement Program. And again, that is going to be funded differently. It's going to be funded strictly through a portion of money that's outside of the capitation rates, and it will not rely on disincentives in order to fund that program. Next, we were asked to comment on when we were planning on resuming the collection of MCHIP premium payments. We are targeting May 1st of 2024. And the reason for this is in order for Maryland to continue to get the enhanced federal dollars that's coming through because of the federal public health emergency, there is a maintenance of effort requirement, meaning that we cannot disenroll, charge a premium until people go through the redetermination process. And we have figured and calculated our plan is to have that all completed by April of 2024. Next, we were asked to comment on an update on where we are with the funds that went to Medicare Advantage plans and skilled nursing programs. We have outlined the schedule of payments. Medicare Advantage plans received a portion of their payment when they signed the contract. They also received a payment just recently, February 28th. May 31st is their next payment, and then the following and last payment is August 31st. There is also payments going to nursing homes. It varied based on the size of the nursing home, which was calculated on their payments that they received by Medicaid. All of those funds have been, the first round of funding have been released, and they should get them in the next couple of weeks. Next, we were asked to report on the timing of the collection of our 2020 risk corridor payment. And what I can say, it's just a matter of timing. When we were putting together the fiscal year 21 budget, it was in October of 2021. We didn't know how much we were going to collect from risk corridors. This is a pandemic. We've actually never had these types of risk corridors before or understood how utilization was happening with our MCOs and our population. So we didn't estimate what we were going to collect, but we do know we're going to get 35 million, and we will build that back into a reversion at the end of the year. Next, we were asked to comment about using cigarette restitution funds in place of general funds, and the department respectfully disagrees with that and supports the governor's budget. Next, we were asked to comment of whether or not we would support the submission of enrollment reports due to the redetermination process that's going to begin in April next month. And also the idea of tying $250,000 or restricting $250,000 in order to see if we're going to submit those reports. And what I will say is we have no problem with giving you those reports. We are going to be required to give those to the CMS on a monthly basis. And they also are tying those reports into our ability to continue to receive the enhanced federal dollars. So we already have a financial incentive to submit those reports and share them. So we will obviously share those with you as well as the public. Next, we were asked to comment about our different enrollment projections and whether or not we could support a $150 million reduction in our budget because of the difference. And I think what we'd like to have is a conversation with Ann and figure out what the right number should be. When we look at the DLS analysis, what we see is about a cut to the Medicaid rolls of about 242,000. And as Ann mentioned, what the secretary mentioned was that we have been continuing to do redeterminations all throughout the pandemic. We have not been disenrolling anyone, but we've been able to identify those individuals who probably most likely are not eligible. So for example, we know that their income is too high. We know that now they're over what would be considered the eligibility under the modified gross adjustment income calculation. And they're getting into the age, blind, and disabled category where they'll have an asset requirement. And that number in terms of what we've identified as potentially not eligible is 187,000. What wasn't included in our budget was the new federal requirement to provide 12 months continuous eligibility for children. That requirement starts January 1st of 2024. Maryland is targeting to implement that early in August. So while children is the number will decrease, we will also see a rise in the number of children covered simply because we're going to implement this new federal requirement of keeping them on Medicaid for a full 12 months. So if you take children out of that 187,000 number, you're getting down to a number that's closer to 132,000, which again is much different than the 242,000 that we're seeing in the DLS analysis. So what we would like to do is just sit down, have a conversation, and understand what makes sense for the budget. Next, we were asked to talk about our staffing and our between contractual PINs as well as our permanent PINs. And what I can say to this is the secretary and this new administration, it is a priority for them to be looking at our staffing across the department and coming forward with a more robust plan. We, of course, thank the governor for the new PINs that we've gotten. We've also outlined in our response all the different special payment payroll positions that we've gotten, the new PINs, and where they're going to be allocated. A lot of these functions will not be temporary functions. They'll be ongoing functions. However, the IT folks, that most of those will just be a temporary function. So with that, I'm going to turn it over to Amelie for the remaining questions.
Thank you. Thank you, Tricia. We were asked to discuss the steps we're taking in the Department of Health to resolve our significant audit finding and explain how we are changing internal accrual tracking processes. And I just want to start and reiterate what the secretary said in her opening remarks. We agree corrective actions are necessary to strengthen our accounting practices and documentation at MDH. And it will take some time to complete, but the current administration, including both the leadership of MDH and DBM, are committed to prioritizing this effort. MDH is working closely with the Department of Budget and Management and the legislative auditors to address the closeout audit findings. A formal action plan has been developed that includes the creation of a joint correction action team, the implementation of control procedures, processing corrective accounting transactions, and identifying any additional resources that may be needed. In fact, we have a scheduled meeting with the joint MDH DBM corrective action team this Wednesday coming up. And on our agenda is to discuss the status of our closeout items and the test samples we were asked to provide. We've been advised that the auditors will provide formal updates to this legislature as corrective actions are taken, and we anticipate that MDH will fully resolve our audit findings. Medicaid specifically has a work group project in place for several months, examining and updating current procedures in place. The first step was to identify and perfect the calculation and timing of adjusting entries to ensure the general versus Medicaid federal versus CHIP federal fund splits are reflected in FEMAS based on the actual quarterly federal claims. Then federal revenues can be matched against the federal expenditures on a quarterly basis. And our goal is to have this portion of the work completed for our fiscal year 23 closeout. We were also asked to provide an update on the implementation of the adult dental coverage expansion, including any plans to change the financing structure for dental services. And the department implemented coverage for adult dental services on January 1st of 2023. As of February 24th, we had just over 27,000 unique unique participants that sought care and 716 unique providers that have billed for just over $9 million. At this time, MDH is not pursuing a capitated payment model for delivery of dental services. And lastly, we were asked to provide 2 reports on CFC and community option waiver financial and registry data, and the department wholeheartedly concurs. We're happy to provide you this information. And that concludes our formal written response, but we are happy to take any questions.
Thank you, Dr. Herrera, Scott, and our team. And I had a couple questions. The first one starts on page 19, dealing with the Medicare Advantage that you had discussed. If you could provide the organizations that were appropriated dollars, the 50 million, and what those dollars were, that would be helpful. So if you could provide that to Ms. Wagner, or if you know, that would be helpful. The second piece was, I wasn't understanding the correlation between Baltimore City and Baltimore County that was recognized within the analysis. So just being able to understand, like, for those that are in that geographic boundary, how did that benefit or not? And if, as we talked in previous discussions, whether the ones that pulled out was able to benefit from this $50 million, I would hope not, but I don't know that because I don't know the organizations. And if you could just comment on this appropriation was already made, these organizations are already decided, but if there is an appropriation that you all are thinking about from fiscal year 2024.
So for the first 2, can we get back to you and
Yes,
get
ma'am.
you the list? For the last one, I will say, no, it's not an appropriation that we are considering. It is a federal program. We do have a meeting with CMMI coming up, I think March 15th, and it's to discuss the waiver as it exists now, but we will be discussing this issue as well. But as far as any ask that we're making for the department on behalf of the MA coalition and its payers that belong to the coalition at this time, no.
Okay. The second question is in reference to page 39, dealing specifically with the OLA audit finding. We referenced the 862 million, but it's also referenced in there that it's been claimed. But the $3.5 billion, could you provide, and I understand that it was a sample of 16, could you provide the programs that was impacted? I wasn't able to get that from the analysis or understand what programs were impacted from that standpoint. And also, I understand that you all are working in coordination with a number of folks to address and correct this action, but I couldn't really understand the timeline. So I would love to hear, like, the timeline that we can have for the expectation for this would be addressed.
So we're still digging in and we're working through this, but we're happy to, I can provide you the 16 samples and the programs that are associated with it in writing, if that's okay.
Yes,
and then we have our meeting on Wednesday with DBM and the joint team, and we should be able to establish a more formal timeline at that point too, once we can share some additional information with them.
Perfect. And these next questions just come from some of the written testimony that was given, and just giving you the opportunity to comment because you go before them from that standpoint. With Lifespan, they provided written testimony and it talked about administrative delays. Just wanted to get you all, if you have any comments that you wanted to provide in reference to the challenges that they were talking around the administrative delays.
So we do know there's a couple of administrative delays. It's in our problem resolution unit, and we are aware of it and we are working on it. We have 2 nursing homes. We delayed, it's a bit complicated, but each year we give them a working capital fund. And it's based on prior in Medicaid billing. What we have done is we've frozen it, so it's still pre-pandemic times, and we're relooking at that issue. But we are aware of the backlog and we are working on it. And we also are aware of the backlog around care plans. And we have a solution going forward where we're going to be doing hopefully an emergency contract to get a vendor on board to help us with those.
Perfect, and thank you. The second one came from HFAM. They talked about the 4% increase in the Medicaid rate, but they also talked about if the $15 minimum wage went, and also the additional 4% was, if you just wanted to provide any comments or thoughts around that for the nursing homes.
Other than we're very happy that the governor did put that in our budget. That's the only comment I have towards that. We're really excited about it and to be able to offer that to our providers.
Yes, ma'am. And the last question comes from the testimony that was provided by Mental Health Association of Maryland, and they suggested two bills, Senate Bill 101 and Senate Bill 362. Just wanted to see if you had any comments to provide on those bills, because they talked about a variation of issues, but these bills will provide solutions to the issues that they went through in the letter.
I think what's going to be coming from the department and is a list of our priorities around behavioral health. As you know, the governor put $70 million in general fund in our behavioral health budget. In addition, there was a supplemental last year that had $35 million. Again, that's just the general funds. It doesn't include the federal funds that we would get on any Medicaid expansion. And so the 70 million wasn't attached to any one program. And so we are coming back with a comprehensive strategy in terms of the short term and long term, in terms of where we're going with behavioral health services. And that will be our response to those bills.
Yes, ma'am. Thank you. Senator Jennings.
I have two questions. The first, it's either for the analyst or the department. On page 50, exhibit 19. Look, I understand this is a very emotional issue. I'm not asking the question to get into it on that. I'm just looking at where the numbers come from. Of the 11,567 procedures, 96% came from number 3. And I just figured number 4 would be higher than less than 10. You don't have to answer it now. I just don't know.
I'm sorry, which page?
Which page again?
Page 50. And again, you don't have to get into it now. I just don't know where this data came from, because
It came from us. So we submit it every year, and it's always included in the DLS analysis.
is this from the hospitals? I mean, is this the patients giving this reasoning?
No, there's a form that must be filled out currently that
Okay.
providers have to keep.
Okay, then that answers the question. It's coming from the patient for
Yes.
the reasoning.
So I don't want to say that with certainty. I will say, to air some dirty laundry, I don't think we do a good job of footnoting which data source it comes from within the department. And so as a general rule, moving forward, our data sources will be footnote at the data source it comes from. So it won't just say MDH, but it'll say MDH, public health, and then
Okay.
what the data source is. So I can't tell by looking at the data source. So I don't want to overpromise
No, I
if it
understand. I
came
just-
from the patient.
Looking at the numbers,
Okay.
it was kind of like, you would think some of those other numbers would be a little higher for reasonings.
We can go back and look
Other-
at the data once I understand the data source and get back to you, but
Yeah.
moving forward in the future, there will be more details to the reference so we can tell you more about the database and the kinds of information we get out of it to answer your
Yeah,
question.
and my questioning is not about the overarching issue. My question is just looking at data, you're like, just these numbers it seems like a bell curve that we're all, I don't know. The last question I had was the Healthy Smiles Dental Program. I know you guys put out an RFP. I think it was due in November, and just curious of when you're expecting to award that. I've had some people.
Well, it's currently under review right
So it's
now,
under
which
review.
Amelie just testified to. So obviously relatively shortly, I don't have
So
an
the
exact.
Healthy Smiles is the same as the adult program
Yes,
you mentioned? Okay.
it's the same dental ASO, Administrative Service Organization vendor. They provide all of our dental services for children, pregnant women, and now adults.
Okay, and so it's under review, you don't have a date yet when it's
They
done?
don't have a date.
Thank you.
Yes, sir. Senator Hedelman.
Thank you, Mr. Chairman. Just following up on the dental issue, this is the first year that we've had the adult, and I had a couple dentists in my office recently who talked about kind of their surprise at how large these numbers are. And I just wanted to give you an opportunity to comment on whether you think the participation sort of surpassed what your expectations were.
I'm not quite sure what numbers you're referencing. So we started in January 1st of the program. So I don't know if they're commenting about the number that are already coming into the office or what. I mean, you know, we'll obviously be monitoring it. Our goal is to obviously provide the most number of dental services available to our Medicaid population. So it's actually encouraging if you're telling me that they're actually
Like
able.
through the
and-
roof.
Okay, so
I don't know if you were having any sense of it.
no, not right now. You know, there's a lag in payment that comes in from claims, so it'll be a while before we really see some of that analysis. What we do know is obviously we understand the new population that dentists are taking on. We put $20 million in our budget last year for dental rate increases. There is a new $20 million for this year. And how it works is we work with the dental community in order to identify the procedures that will most impact their practices and help them sustain what they're experiencing in Medicaid.
Thank you.
Thank you, Senator Hedelman. And this being the end of the agency piece of it, we have public testimony. Just want to say thank you for your leadership, Dr. Herrera, Scott, and your team, and look forward to the responses that's provided to Ms. Wagner. At this time, we have a number of witnesses that are going to be testifying. The first one will be Joseph D'Amatos from HFAM, and we're going to limit testimony to 2 minutes if possible.
Mr. Chairman, members of the committee, thank you so much for the opportunity to testify in support of the budget. Joe D'Amatos, President and CEO of the Health Facilities Association of Maryland. HFAM has been around for 76 years. We represent skilled nursing rehab centers, assisted living centers, and associate members throughout the state. Yesterday, when I testified in the House, I thanked them for looking out for us during the pandemic. Some of you may know, the only real increase that we've had in our rate over the last several years and throughout the pandemic was this fight for 4% and the additional 4% that we got last year. And today, what I want to tell you about the 4% is I want to thank this committee because it was the brainchild of Senator Gazzoni and this committee that got that 4% for Fight for 15 when we supported it those years ago. Last 2 points. To the extent that the acceleration of the minimum wage happens, we are counting on this committee and your colleagues in both chambers to support that with funding. If the acceleration is 1 year, 1 year funding. If the acceleration is 2 years, 2 years of funding. We think that's really important. And then finally, just about nursing homes right now, we're still dealing with the endemic forces of COVID-19. So in short, if you look at nursing homes right now, the majority of our expense is in nursing. The majority of our expense is in wages and benefits. We're at a time where occupancy is low, costs are high. So we appreciate your support of the budget. Thank you, Mr. Chairman. You have my testimony. I'm prepared to answer any questions.
Seeing no questions, thank you, Mr. D'Amatos.
Thank you, Mr. Chairman, members of the committee.
Colleagues, at this time, I'm going to call up Ms. Laura Hale from the American Heart Association. Not seeing Ms. Hale, I'm going to move to the next person that wants to give public testimony, which is Brian Frazee from the Maryland Hospital Association.
Good afternoon, Mr. Chairman, members of the subcommittee. Brian Frazee here on behalf of the Maryland Hospital Association in strong support of the Medicaid budget. The governor did include, and we want to thank Governor Moore for including a one-time $50 million reduction to the Medicaid deficit assessment in his proposed fiscal year 24 budget, which is in the Medicaid program. That is important because it goes directly toward reducing patients' hospital bills. That assessment actually artificially inflates healthcare spending in Maryland, and we are at a critical time right now as we enter renegotiations with the federal government on the total cost of care model. So our ask is that you protect that reduction. Again, we want to thank the governor. We fully support the budget. Thank you.
And thank you, Mr. Frazee. Seeing no questions, we'll call up the next witness. Colleagues, we're going to have Dana Kaufman from Lifespan.
Thank you very much, Mr. Chairman, members of the committee. Dana Kaufman for the record on behalf of Lifespan, as well as the Maryland Association of Adult Day Services and the Maryland National Capital Home Care. Thank you for recognizing the comments regarding the delays. The reason we do bring that up is not only does it impact services, but it also, of course, impacts revenue and the ability to be able to recover fully from the COVID-19 pandemic. And we look forward to working with the health department on their resolution of that. The only other issue I want to bring up, and you have my written testimony for both organizations, is on the home and community-based services for the rate increases. We're very grateful to have that monies put into the budget, and also the acceleration of the rate increases if the minimum wage does go up to $15 an hour. But I did just want to make a clarifying point, and this was put into, I think, the analysis, is that for the home and community-based services, for at least this coming fiscal year, for the 4%, they are actually level funded. And that is because the ARPA funds that were given to them, the 4%, it was very stated upfront that it was a 1%, a one-time increase. But that 4% does go away June 30th. And then the 4% that is in the budget takes its place. So it does become a net effect. And, those funds were given. And then, of course, we saw the huge spikes in inflation. So I just wanted to make a comment about that because, again, these are the home and community-based services. They have been hit very hard by a lot of the inflationary increases and the workforce shortages. Just be aware that it's a flat fee, not a 4% actually for them net effect. So thank you very much.
Yes, ma'am, and thank you. Seeing no questions, we'll bring up the next person, Ms. Jocelyn Buchanan.
Good afternoon, Mr. Chairman, members of the committee. My name is Jocelyn Buchanan. I'm the Director of Nursing for Comprehensive Nursing Services. We provide private duty nursing services to medically fragile, technology-dependent children in their homes in the Baltimore area. Over 80% of our clients actually do rely on Maryland Medicaid for their services. As you consider your budget, I just want to highlight the private duty nursing reimbursement rate. The proposed 4% increase, while appreciated, is not going to bring us to a level that's commensurate with our surrounding states. Even with that increase, excuse me, Maryland rates will remain lower than all surrounding states, including Delaware, the District of Columbia, Northern Virginia, West Virginia, and Pennsylvania. This disparity is contributing to the severity of the nursing shortage. Nurses working in home care are leaving the state because they can cross the state line and make significantly more money. Currently, an estimated 31,000 nurses that are licensed in Maryland do not work in the state of Maryland. As a residential service agency, our ability to fill open nursing hours has declined from pre-pandemic around 90% to about 80%, which still, sounds really great. But when you think about it, that's 1 in 5 shifts that are open, 1 in 5 days that parents are going without work or without sleep. An increase in this reimbursement rate to be commensurate with surrounding states is something that we believe would immediately impact our ability to draw nurses back into the state of Maryland. Also, just to raise awareness, currently Maryland does have an RN reimbursement rate, but it's not able to be utilized unless the patient has a technology that's outside the scope of practice for a registered nurse, which does not happen that often in home care. And many RNs within the state of Maryland are unwilling to work for the lower LPN reimbursement rate. Currently, RNs in Maryland outnumber LPNs by a rate of 8 to 1, and the LPN workforce is rapidly dwindling. There are simply not enough home care nurses to meet the current home care demand in the state. Once again, I appreciate the opportunity to speak here today. Thank you.
Thank you, and thank you for your service. Seeing no questions, colleagues, I'm going to bring up the last witness testimony, which is Art Estopinan.
Yes.
Hope I was good.
Yeah, you were good. Very good. Thank you, Mr. Chairman, members of the committee. It is indeed a great honor and pleasure to have the opportunity to represent a grassroots organization known as FAME, Families Advocating for Medical Complex Patients at Home Enacting Change. We started this group for families that rely on home care nursing for themselves and their loved ones. We have recognized a need for reform in the state of Maryland to increase the availability of home care nurses. As a former retired federal employee for almost three decades in the United States Congress, I would like to thank each one of you in this distinguished committee for your service to help the residents as your role as a legislator, and also for your commitment to help disabled citizens in the state. Many of our loved ones will be unable to live. For example, my son is on a ventilator. He is now 12 years old, but he was told when he was 17 months that he would only have 2 more months to live. The nursing care at home has been truly crucial for us, for my wife and I, to be able to provide that service. We had to recreate our home. First of all, we moved from Arlington, Virginia to Baltimore to be close to Johns Hopkins. And we had to really educate ourselves. And due to the help of the nurses at home, he has been able to thrive. But without the pivotal assistance that the state of Maryland provides, we would be unable to take care of him. We are so very grateful. However, due to competing factors of care in other healthcare industries in Maryland, nurses have started leaving their professional work in this state and have moved on to surrounding states. The nursing shortage in Maryland has been further exacerbated by the COVID-19 pandemic. Our families are going without much needed sleep, missing out on employment opportunities, and struggling to juggle day-to-day activities without the assistance of home health care services, which simply are not available in a large enough number to supply the current need. As a group, we're working to enact reform to legislative and regulatory requirements that we feel, if enacted, would make an impact on the availability of home healthcare nurses in the state. The changes include immediately increasing the MA home duty nursing reimbursement rates to help the reimbursement rate for the surrounding, to be competitive with the reimbursement rates of the surrounding states.
And if you could begin to wrap it up.
Yes, sir. Maryland reimbursement rate as it's stated has been lower. Delaware, Pennsylvania, District of Columbia, West Virginia, and Northern Virginia. Number 2, allow new grads, nursing grads, to work in the home healthcare industry. Currently, nurses must work 1 year of clinical experience to be able to work in home. Number 3, and then I have just one more, allow the existing RN reimbursement rate to be utilized for all RNs working in home health care instead of allowing the rate to only be utilized for specific patients based on technology. And lastly, remove the regulation that restricts home care nurses from working only 60 hours per week. So once again, on behalf of FAME, I would like to thank each one of you for your support and interest in helping the members of the disabled community in our beautiful state of Maryland. Thank you very much.
Thank you also. And colleagues, seeing no further questions at the moment, I do want to just take the time out to thank Ms. Wagner for our due diligence and comprehensive analysis for this very intense analysis. Colleagues, we'll see you tomorrow, and just want to say thank you again. Sure.
Would this be better or on the side? Well, maybe both. And did you want on this? Yes, from the side.
Yeah.